Now that it's not a matter of if, but of when your turn will come for the COVID-19 vaccine, will you take it? The answers that people give to that question could make or break this crisis. Many can't roll up their sleeves fast enough. Others are still unsure. Why and what do those who are hesitant need to know? Well, let's find out from some of the experts. From the nation's capital, we welcome Dr. Supriya Sharma. She is Chief Medical Advisor at Health Canada. And in our provincial capital, Dr. Samantha Hill, President of the Ontario Medical Association. Maya Goldenberg, Associate Professor of Philosophy at the University of Guelph and author of the forthcoming book, Vaccine Hesitancy, Public Trust, Expertise, and the War on Science. And Samantha Hill is here. She is a neuroscientist and science communicator, also known as Science Sam. And it's great to welcome you four to TVO tonight. I just want to start our discussion by putting some facts on the table here. Professors Peter Lowen, Taylor Owen, and Derek Ruths co-lead something called the Media Ecosystem Observatory. And they just published a report about vaccine hesitancy in Canada, surveying, I think, almost 40,000 people. So this is a pretty deep dive on this. Only 2/3, 65% of Canadians are currently willing to take a vaccine. Opinions are stable, and there appears little that can be done to convince the 15% who are unwilling. The 20% who are unsure need to be convinced of the efficacy and safety of a vaccine, which could be difficult given high levels of distrust and an increasingly loud and chaotic information ecosystem. Figuring out how to reach these Canadians is as important as procuring another 1 million doses of a vaccine. That last line is huge. So I guess we should say that much of the advice we're going to hear from you for tonight will focus on that 20% that is persuadable but still hesitant. Dr. Sharma, let's start with this. If the numbers, as I've just outlined them, persist, how would that affect this country's ability to achieve herd immunity?
Well, I think it's just with any vaccine, even the best vaccine. So even if it's got the highest efficacy, it only works if somebody gets it. It's if it's administered. So someone has to agree to get it and then have it administered to them. And we already know for the vaccines that we have that there are some populations where we will not be vaccinating them yet. So for children, for some other groups, for example, because they haven't been tested. So that's why it's really important for the adults who are eligible to get the vaccine to be vaccinated. So, we see that we don't know exactly what the herd immunity level should be at this point in time for COVID, but we're estimating that it should be around 60 to 70%. So, we do need large numbers of people to come forward and to agree to be vaccinated, of course, in Canada.
Right. Dr. Samantha Hill, when you look at those numbers, what goes through your mind?
So honestly, I'm a little bit concerned, but I feel poorly because I think that we as a community haven't done a great job of explaining it. If there's still 20% of people who are uncertain, I don't like the word convincing. I don't think I'm trying to convince anyone. What I think our job here is to provide the evidence, provide the understanding, clear up the misinformation that abounds on the internet, and then let people make the right decision for them. For most people, that actually will be to get the vaccine. But I do believe we have to trust in people to make the right decision with the right support.
All right. That having been said, Maya Goldenberg, do you have any issues with those numbers as they've been presented?
Well, those numbers are pretty consistent with what we know about vaccine hesitancy in other contexts. So pediatric vaccines usually polls at about 2/3 of Canadian parents with young children are plan to vaccinate their children. So knowing that people came into this landscape of discussion around COVID vaccines with prior feelings about vaccines, it's not too surprising and actually not too concerning that the numbers match each other. This is a new vaccine. The context is very different from the kind of decision making that people have had to make around pediatric vaccines. So it doesn't surprise me too much that we're seeing similar numbers. And I think we can use the kind of strategies that have worked around pediatric vaccines and channel that towards COVID vaccination too.
Okay, Samantha, let me follow up with you on that angle and those numbers again. Do you have any reason to be suspicious about the accuracy of those numbers?
I think when it comes to any human data, and especially data where people are self-reporting, we have to be mindful that there are caveats and limitations to these types of studies. And so in that case, I wonder how helpful they are when we, broadly discuss them. It's important for policymakers and public health officials to think about vaccine hesitancy and these rates. But when we think about them more broadly, vaccine hesitancy itself is contagious. And the more we say, people are hesitant, the more people start to question where they may not have before. And we have to keep in mind when talking about these data that, there are biases to these types of self-reporting studies. There's something called the social desirability bias. People want to give an answer that they think other people will approve of, and that might change the answer that they give. There's also priming. You don't know what someone had just seen right before they answered this type of survey. And so we always have to take these types of studies with a grain of salt and know that someone's intention to vaccinate may not translate to what they actually do. So whenever you see these types of numbers, just think, maybe I'm not going to let that affect me, because who knows how this study was done, who knows when it was done, all these things. And try to just remember that your decision should be about your personal health and what you need to do to protect yourself, your community, and your family.
Well, that's an interesting point. Maya Goldenberg, let me follow up with you on that, because I know in politics, how you ask the question matters hugely. And I guess in this case, if you were to say, are you up for taking the COVID-19 vaccine? That might get you one set of answers. But if you were to say, would you be open to taking a vaccine which would prevent you from being one of the 1,000 people that die every single day from a horrible illness that will make your last days on Earth miserable, you might get a very different answer. Fair to say?
Oh, that's very fair to say. And I think social scientists are aware of that. How you ask the question is really important. And I agree completely with the previous statements that intention and action don't always line up. When I see these, when I see these kinds of studies, I'm looking at how many people are saying that they do plan to get the COVID vaccine. And that's because we happen to know from previous vaccination efforts that the best way to get people to vaccinate is to make it the normal thing to do. So you do things like you focus on the numbers who do want to do it. Right now, physicians are taking selfies showing themselves being vaccinated. So they're sending an image that this is a normal thing to do, not an exceptional thing to do. And people see that, and that's going to have much more influence than focusing on the people that don't want to get vaccinated.
Well, I do wonder about that. I mean, that what you've said makes perfect sense. But Dr. Hill, I note just before the holidays, Quebec long-term care home made news for the fact that, imagine this, in long-term care homes, which is really the front lines against COVID-19, only 35 to 40% of staff plan to get the vaccine. And this week, the head of the Ontario Personal Support Workers Association, that's our province, said that more than half of its members don't want to get vaccinated. What do we do about that?
Well, I think we start from where the other Samantha said, which is that we don't know what those numbers exactly mean, but they certainly are headline worthy and they are media catching. Where we go with it, though, is to acknowledge that there is some proportion that is not negligible of even healthcare workers who are voicing concern. And that's a big problem for two reasons. The first is that they themselves may not get vaccinated, which puts them at risk and puts their population that they're tending to at risk. But the other part is that it sends a signal on media and to their family that if healthcare workers have a concern, perhaps this isn't as well established as the authorities would have you believe. And so I think that's part of the discussion we need to have. When we talk about vaccine hesitancy, it's really about where misinformation and mistrust collide. And so those are the two things that we need to keep coming back to. Some of them are social determinants, and some of them are going to take us years to work around, particularly when you think about the different cultures that people come from and the different experiences they may have had historically. But some of it is really just a question of misinformation. And so when people tell me that they're worried that the vaccine will incorporate with their DNA, for example, and change their genetic composition, I point out that we don't have the capacity to do that in the human body, much the same way, and I love this line, so I'm going to use it, as when you eat a steak, you don't turn into a cow. We go in one direction, and that's DNA to RNA to protein. And having a piece of RNA that is not actually the virus put into your body has no possibility of changing your own genetic code. And when people hear that, and when they hear a real life example that's so obvious, like the steak and the cow, it resonates and they're reassured. And when people are reassured, they're in a better place to make good decisions.
All right, following up with Dr. Sharma on that, though, if the people who are most at risk of dying of COVID-19, and that's, in some respects, the people who take care of the people, 70% of who, I'm not saying this well, 70% of the deaths in the province of Ontario are people who live in long-term care homes. The people who take care of those people are therefore on the front lines of care. They seem to be among the most vulnerable as well to die from this thing. And if fewer than half of them want to take this potential life-saving option, what signal does that send, Dr. Sharma?
Sure. Well, I think, just echoing some of the other comments, it's what is that data, right? So when we're looking at it, I think what we found with healthcare professionals is that, a lot of them are saying that they don't want to get it right now. So for example, they would say, I wouldn't be in the first round, but as other people get it, then I might get it. We also know that whether it's healthcare professionals in long-term care or other facilities, if you bring the vaccine to them, so if you make it very easy and make it easily accessible, they're more likely to get it as well. So I think, what the key is that we need to make sure that people get information and we meet them where they are. So we're not this one big monolithic blob. We all have different risk perceptions. There are some people that go skydiving or bungee jumping. There are people that don't. And so, you really need to have that information. What we've said, at the federal level with respect to Health Canada and the vaccines is that we're going to be really open and transparent with you. We're going to tell you what we know and what we don't know and what we have in terms of plans of knowing more about the vaccine. And then putting that information out there, working with the provinces and territories. We know that people in general across the board respond to information from peers or people that they know in different ways compared to, large organizations that are very distant from them. So I think we need to take this information. It's really important, but really focus on what do people need to get them to a yes, right? So, and again, it's not convincing them. It's having that information available so they can access it whenever they need it and be able to make what we think is the most appropriate decision.
Fair enough, but information can only combat so much. And I think, Samantha, let me ask you this, and I don't say this facetiously. Some people are terrified of needles. And we have seen the needles of this COVID-19 vaccine. And if you're scared of needles, those things look pretty scary. What do we do about that?
I'm going to start off by saying I'm one of those people. I am very terrified of them. I, try to avoid it if I can. In this case, I am still, despite that fear, really excited to get this vaccine just because of the year we've had. I just want to say having a fear of needles is somewhat common, and I understand that anxiety so deeply. But I think that's a time where we need to reach out to our healthcare professionals, ask for the support that we need, and address that fear of the needle and not conflate it with the fear of what's inside the needle. And that's why I've been actually really happy to see so many people sharing their vaccination pictures, because it's helped to, it's been a bit of exposure therapy, informal exposure therapy, just to see all of these masked, but you can see the crinkly smiling eyes receiving the needle and reminding me that it doesn't need to be a scary experience. And in fact, this is exciting when we think scientifically what's been achieved here. So I think if you have those fears, I understand there is help you can get and support that you deserve for that. But remember that it's two separate things. There's a needle and there's what's inside of it. And what's inside of it is something we really need to help us get out of this huge crisis.
Well, Maya Goldenberg, let me get you to follow up on that, in as much as I know when Anthony Fauci got his shot, we were probably all watching that photo op to see if he was going to flinch, and he did not. He took it like a champ. And so did that 91-year-old woman in Great Britain, who was the first person ever to be vaccinated. She took it like a champ as well. But I have seen some pictures on TV, I have to confess, of people getting the needle and saying, ouch. How influential are those kinds of pictures when you're trying to get the message out that it's not just the needle, it's what's inside the bottle as well that counts?
Look, everything will play into it, but it doesn't mean that one ouch picture is going to change the situation. It's nice that it's out there. It's nice that it's honest. I like the attention to things like needle fear, that we don't marginalize it. We say this is an important feature of the healthcare decisions that we're making. I don't see it as particularly problematic to know that some people say, ouch. I think it's great to be explicit about it. People are also sharing their experiences of muscle pain or what kind of effects they had in the days after. People would rather know than not know, because when they don't know, they fill in all kinds of gaps.
Okay, Dr. Sharma, let me come back to you with this next one. I have heard people say, this vaccine got developed in record time, and I am dubious as to whether or not it got adequately tested. And before I put anything into my body, I'd sure like to know that it was appropriately tested. What could you say to that group of people to allay those concerns?
Well, first of all, I would say it's good that people are asking the question. I think it's important for people before they take something to be aware of what they're taking and why. But I think, we are in this incredible time where, the fact that we have vaccines less than a year from when we knew the genetic code of this virus is an amazing scientific marvel. And I can understand when people hear this, the concept of normally when we have vaccines, it takes years to develop. This has been less than a year and we've reviewed it very quickly. But the thing that's the most important to highlight is that no steps were skipped. So there was no corners cut. It's still, the development of these vaccines are going through every phase that a vaccine would go through, not in pandemic times. And although, at the Health Canada perspective, we did review it in a shorter period of time, we still went through all the steps. We just had a dedicated team that was working on it. It still takes on average 2,000 hours of review time of a group of scientific reviewers that are about 7 to 10 people that are going through tens of thousands, hundreds of thousands of pages and analyzing that before it's authorized. And I think, the important part of this is that there's different phases for vaccine development for a reason. You get early candidates, some of them make it through, some of them don't, but you actually have to have them go through and make it through every stage to get to the point where they're even in clinical trials. And, I think people also should know that when we're looking at, for example, the Pfizer and the Moderna vaccines, the studies were tens of thousands of people. And so, we do know a lot about these vaccines, and they're really being held to the same standards that any vaccine would. It's just that we're doing all of this in a compressed time.
Okay, but even amidst all of those thousands and thousands of people, Dr. Hill, let me get you on this one. Not kids and not pregnant women. So what does one say to them?
So they're actually a very different population. The three populations that come to mind most closely are children, immunocompromised, and pregnant women, all of which we just don't have enough data on to say things are absolutely safe. And that's a key sentence. It's not that we have ever said, and we being the medical community, that it is unsafe. It's that we don't have the data to say that it is safe. And that is routine for any scientific trial. You always try things out on your best studied population first, which is, your typical adult, before you study the subpopulations because of the risks that are associated. Children are not miniature adults. They have a different immune system and things sometimes work differently for them. We know that many pediatric vaccines require multiple doses and multiple boosters to achieve a decent immunity. And so that needs to be taken into account. With respect to breastfeeding women, what I think we all have to be very careful about saying is that they can't receive it. What the actual statement is that it needs to be risk balanced. And so that means that there's an individual discussion that has to happen with the pregnant woman and their physician or primary care provider around what their personal risks are of acquiring COVID, the risk that they maintain as a pregnant individual if they get COVID, which is much higher than the average, and the risk of getting the vaccine. And then they have to make a decision for themselves. That also includes the same population of lactating women. We can't as a group say that we will deny access to that population because First of all, it's a question of when. Eventually, I expect the studies will be there and we'll be able to open it up, but also because that would be a systematic disenfranchisement of women from their own healthcare. Medical women, healthcare women, nurses, PSWs, physicians are in a very different risk category than the general population. We cannot keep ourselves away from the COVID virus. And so that discussion has to play out very differently than the discussion with the general population.
In which case, let's talk communication. And I'll go to Samantha Yamin on this one. You've got the woman representing all of Ontario's doctors right here, right? Samantha Hill is the head of the OMA. In which case, what would you like to hear doctors communicate about the advisability of taking this vaccine that you maybe haven't heard so far?
I think that's a good question. I think it's really important that we address people's questions. I think instead of just making sweeping statements like, yes, take it, we need to ask people what they're really concerned about. There are some folks, vaccine hesitant people are not a monolith, as we mentioned. There's many different reasons people are hesitant, and that hesitancy really just means they have questions. Some people might have historical reasons why they mistrust government and large organizations, and those are very valid. I'm not here to say that isn't, but it means we maybe need to be more transparent about the process and the people involved. There are good people. There's representation in the scientific process. There are people who care about the same challenges you may be thinking and the same concerns you may have. There are people within the process that have those same concerns. There are independent scientists outside of the process, like myself, who are reviewing things as well and have your best interests at heart. And I think that kind of granularity, the validation that the questions are important and addressing them head on is really key. And when it comes to the long-term safety, just reminding people that most adverse events happen within 6 weeks to 3 months. The first injection from a phase 1 clinical trial was March 16th of 2020. So we've had a long enough window to observe any potential adverse events. Unfortunately, there really haven't been many more than you would expect from the general population. And especially when you compare to the adverse events from COVID, that's what we have to keep in mind. Is this vaccine better than the current standard of care, which for COVID is very limited? And so far, yes, it really, really is.
In other words, if it was a problem, we'd know by now.
Yes.
Got it. Okay. Let's talk trust for a second here, shall we? And Maya Goldenberg, I'm going to bring you in on this because you've got a book about this, which is not out actually for a couple of months, but we got a sneak preview. And I'm going to read a little snippet of it here. Sheldon, the graphic, if you would. Public health and vaccine advocates are aware of poor public trust in vaccines, but see this as a problem with the public's rather than signaling one in scientific governance. Vaccine pundits often contribute to public shaming and disparaging of vaccine hesitators and refusers rather than trying to build bridges. This lack of priority must be rethought, given that public health is so dependent on public trust for achieving its community health goals. The lesson here is that public trust is hard won. Biomedical and scientific institutions cannot take it as a given that they should be trusted. Instead, trust must be earned and maintained. Okay, boy, so many questions coming out of that. Starting with, how?
Well, let me go back a little bit on the importance of trust here. If I could give a message to all Ontario doctors, because we have Dr. Hill here, it would be that all conversations with the general public should be approached with the understanding that it is reasonable for people to be skeptical about a new vaccine. One, because it's new, but also because people have questions, and it's okay to have questions. I've said this about pediatric vaccines, which have a far longer record than the COVID vaccine, so a much stronger track record. There is the tendency among scientists and health professionals to regard vaccine hesitancy as a problem of misinformation or scientific illiteracy. Scientific illiteracy as being the primary problem, and therefore the solution to that would be to educate the public and to provide the facts that they need. Of course, fact-driven information is important, but a lot of the fear and discomfort around vaccines comes from problems of mistrust. And that's got much more to do with the social circumstances that people find themselves in. So I'm not surprised at all that long-term care workers are hesitating around the vaccine. Even though the risk-benefit seems to stand out, these are largely racialized and immigrant women who have really borne the brunt of the disparities noticed through COVID. So the fact that the system did not protect long-term care workers during this pandemic, or did not protect them well, it shouldn't be too surprising that they don't turn towards the system for the solution, which right now is a COVID vaccine. So the kinds of trust building that we need is much more than provision of good information. Of course we need that, but we really need to be building bridges and addressing historic and current injustices all around us.
No, appreciate that answer, and I see Dr. Hill applauding that, and I guess I'd remind everybody that the first thing Dr. Hill said in our discussion was she's not here to convince anybody to take it. She wants to put information out there and just make this as clear as possible. Let me pick up, Maya Goldenberg, on one thing you said there, and you were talking about ethnic communities and why some racialized communities, for example, might be even more hesitant than others to take this. What would be the historical underpinnings of that?
The historical underpinnings are medical racism, medical misconduct on marginalized communities. We have a long history of that, and we can't just erase that and pretend that it's an artifact. We still deal with disparities of health based on race, based on ethnicity and socioeconomic status today. So the people that are hesitating around vaccines live that and don't see the technological solution as the big answer. In fact, if anything, COVID has exposed more overtly the kind of disparities that people deal with every day. So the kind of transformation that we need, which will likely result in more uptake of vaccines, is much broader than health information. You have to create systems that people trust and that they see as acting in their own community's interests. And not everyone feels that way about public health and Canadian healthcare.
Understood. In our last few minutes here, let's talk about how we build those bridges. Dr. Hill, let me get you in here. How should people talk to their loved ones who have doubts about taking this vaccine?
Thanks. It's such a great question. And it's not just your loved ones. I'm going to speak to every single healthcare provider out there when you're talking to communities. I want to quote something someone else said on this emission, which was that hesitation is okay. Questions are okay. Uncertainty is okay. And we have to start from a place where we don't expect people to kowtow or to immediately obey. Free will is important and free choice is important. And possibly even more important than survival from COVID is your free will and your free choice. And you need to start every conversation from that place. You also have to start every single conversation from a place of respect. And that means understanding the why. And that's what we've danced around for a lot of this session is we've talked about the numbers of people who are hesitant, but we're not talking about the why. And sometimes the whys are personal and they can be addressed with education, which really isn't just about providing information, but how you provide it and making sure it's heard and making sure it's accessible. But it's also about the cultural phenomenons. And we know the stories of Tuskegee and we know the stories that have predated and led us to a place where, frankly, many of our Black population don't trust healthcare. And for them and to them, I would say we need to remember that there are details that are important, like the fact that the Moderna vaccine had 37% representation in the BIPOC community or people of color. So that community in this vaccine has been studied. But we also need to remember who led that vaccine, right? It wasn't someone who looks like me. It's someone who looks a lot more like them. It was a Black female scientist who was the head scientist on that study. And I think we need to put those figures in front and make them visible so that people can see people who look like them, hear people who talk like them, and understand that those people come from the same communities that they do. And that makes that trust a little bit more accessible, but that trust is going to take a long time to earn. When speaking with your loved ones, what I would suggest most strongly is don't burn bridges over this. It's been a hard year for everyone. Leave the space open to come back to a conversation and have it again later. The truth of the matter is right now in Ontario, we have 150,000 vaccines, 40% have been given. We have time to have those conversations. I'd love to say we get 14 million vaccines coming in tomorrow and we have to figure this all out right now, but we don't. We have time. The pressure is there, but we can take time and give people time to have space to come to the right decision in their own, one more time.
Samantha Yamin, I've got 30 seconds left. You want to give us the last word on that angle?
Absolutely. I think it's really easy to feel really intense and angry, and it gets very emotional. But sometimes it's good to just take a break, take a step back, and really address the root cause of someone's mistrust. And just remind that person you're talking to, like, hey, I care about you. Let's just figure this out so we can all be happy, be safe, and hang out again.
Hanging out again would be very nice, actually. I want to thank the four of you for coming on to TVO tonight and helping us out with this. Dr. Supriya Sharma in Ottawa, Dr. Samantha Hill, who looks like she's in the middle of a forest, but I'm reliably advised she's somewhere in downtown Toronto, Maya Goldenberg, and Samantha Yamin. Great to have all of you aboard tonight. Thank you so much.
Thank you.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.